lecture. I am very pleased to see you here and welcome all of you to this lecture. Today's lecture is about manifestation and histopathology of precancerous lesion, ilmu penyakit mulut dan oral pathology. Ladies and gentlemen, entering the main agenda, lecture about manifestation and histopathology of precancerous lesion, ilmu penyakit mulut dan oral pathology. Our speaker today is Dr. Nurul Mahamad Apandi, Director and Clinical Specialist in Oral Medicine and Oral Pathology, Department of Craniofacial Diagnostic and Biosciences, Fakulti of Dentistry, Universiti Kebangsaan, Malaysia in Kuala Lumpur. She has received her Doctor of Dental Surgery degree at National University of Malaysia in 2014, and in 2021 she taken her master degree at University of Malaya in Masters of Clinical Dentistry, Oral Medicine and Oral Pathology. She is a member of Malaysian Association of Orofacial Disease and Malaysian Dental Association. She has a research from 2017 until 2023. Her research interests including oral cancers, dry mouth, and salivary gland disease. Previously, she has also been involved in the research of salivary gland tumors. She also has several journal publications. In 2024, she published a journal titled Differential Expression of Mucin in Salivary Gland Tumors. She also has experience attending international and national seminars as a participant, speaker, and presenter. She is active in international, national, and university extracurricular committee. She was part of the committee, presenter, and guest speaker. Before the presentation begins, let me inform how the presentation will be going on. First, Dr. Nurul Mahamad Apandi will be invited to presenting the subject. The presentation will last for 2 hours and 30 minutes. After that, there will be Q&A session for 30 minutes. Now, allow me to welcome the speaker, Dr. Nurul Mahamad Apandi, to deliver her presentation. Dr. Nurul Mahamad Apandi, the time is yours.
Thank you very much to the moderator for the kind introduction. You can hear me then?
Yes, I can, Doctor.
Okay. So, Assalamualaikum and salam sejahtera. Okay, thank you to the Dean of Universitas Fakulti Pergigian, Universitas Lambung Mangkurat for the invitation, and also to RG, Dr. Amy. Okay, so I'll just be sharing my screen. Can you view my screen? Nampak ya?
Nampak, Doctor.
Okay, so this topic is actually very dry, so I hope you can bear with me. Okay, so we'll be going through manifestations and also some histopathological slides for some of these precancerous lesions. So we'll be just before introduction. Okay, so this is where I work. Okay, I think maybe some of you have been there for the past 2 weeks. I think we held a national international students symposium. Okay, so for those of you who have come, right? So this is our very small campus in Kuala Lumpur. Right? Okay. So moving on to the topic. So actually, what is a precancerous lesion, or the current term that we use is oral potentially malignant disorder, right? So it's a group of conditions in which there are abnormal tissue changes in the mouth that has a potential to become cancer, or it may have some malignant changes, right? Okay. So the changes can be basically anything, because as I've learned, oral pathology is not always textbook. Okay, so you can have a swelling, any thickening of the mucosa inside the oral cavity. It can be in the form of red or white patches. Okay, So there are some sites which are more high risk potential for them to turn into malignancy. Okay, but basically it can occur at any site. It can occur on your cheek region or your retromolar areas, okay, and also your palatal region. Okay, so what is the significance, okay, so of having an OPND? Okay, so if you have a certain type of precancerous lesion, you are bound to have higher risk of having oral malignancy. Okay, so basically, if it's oral, it's your oral squamous cell carcinoma. Okay, just a bit to touch on history. Okay, so basically, it started.
Recording in progress.
This precancerous lesion started in 1805. Okay, so the first concept was introduced. Okay, so the first term of definitions that they use is your potentially precancerous lesions are suggested they are benign disease that may develop into invasive malignancy if it's followed for a long time. Okay, so however, as time went by, okay, after a few years, okay, the Oral Pathological Society, okay, they've been doing some workshops and also having consensus meeting, okay, to further develop what we are currently using now. So in 2005, there was a workshop, okay, and then they further reconfirmed this working group in 2020. Okay. So the current concept that we use is firstly, your precancerous lesions involve tissue fields with more or less distinctive clinical appearance at initial assessment, and there is a portion within each clinical category that has been documented and usually followed up for quite some time. Okay, meaning the cases after initial presentation, you follow up the case. Okay, so secondly, tissues within this OPMD, okay, are categorized as having high risk potential for malignancy. Okay, and thirdly, some of these clinical alterations include your red and white patches. Okay, sometimes they can coexist together. Okay, and they would further, if left progressive, can progress to become your oral squamous cell carcinoma. Okay, and then they possess similar morphological and cytological changes that you may see in early invasive lesions, okay, or early squamous cell carcinoma. Or I think previously we used to call carcinoma in situ, okay, but we rarely use it now. Okay, so the current types of OPMD, okay, so this is based on the recent consensus, okay, so they listed these lesions as categorized in your OPND. Okay, so I know before this, if you were to refer to your Neville book, if you're using that book, okay, they only mention like 6 lesions, okay, which is I think only up to your actinic keratosis, and also including your palatal lesions in reverse smokers. Okay, so your OLE, oral lupus erythematosus, and this keratosis have been fully added, okay, to be as they along the years, some cases have been reported to have increased rates of malignancies. Okay, so we're going through one by one. Okay, so leukoplakia. Okay, I know you must have heard this term very much in your clinics. Okay, so the WHO definition of this, okay, the current definition that we are still using is it's described as a predominantly white lump, okay, of questionable risk, having that you have excluded any other known diseases and any other white lesions. Okay, so basically leukoplakia is a diagnosis by exclusion. Okay, so seeing that when you have a patient coming to you, okay, leukoplakia won't be the first as a differentials, okay? But for any white lesions, it can be included as a differentials, but it will be at the very bottom, okay, after you've excluded one by one, okay? So, what are the criteria for diagnosis of leukoplakia? Okay, so it's a white patch or more of plaque-like because it's usually a bit thicker than your frictional keratosis, okay? So the first one, it cannot be rubbed off, okay? So it can come in two forms. It's either homogeneous or non-homogeneous, okay? So most of the time, I think leukoplakia that I've seen, okay, most of it are homogeneous types, okay? They consist of a well-defined areas, okay? So basically you can see the outline or the border of the lesions, okay? However, you can also come across non-homogeneous types, okay? So these lesions for non-homogeneous, they are a bit more diffuse, and you'll be having a mixture, okay, of red and also white areas, okay? And sometimes with this kind of lesions, clinically it may look as if it's benign, okay? But sometimes there are already some epithelial changes when you take the lesion for biopsy, okay? So for these lesions also, when you approximate the adjacent areas, you won't be able to find any causative agents, okay? Say for traumatic ulcer, you will be looking at probably the adjacent tooth having any sharp edges or any restorations that having very irregular sides or edges, okay, that might be causing the trauma, okay, but for leukoplakia, that's rarely the case, okay. Another thing is not reversible, okay. So say you find a possible cause of trauma to that area, or maybe habitual biting habits, okay. Some people, when they have a bit of anxiety, okay, they tend to chew on any mucosal area in the oral cavity, okay, because it helps with their anxiety, okay. But after you've reviewed again the patient after some time, okay, after the behavioral management and also removal of any traumatic cause, okay, it doesn't eliminate the lesion, okay, so the lesion is still there, okay, and it does not disappear or fade away upon stretching, okay. So here you have your leukodema, which is a white lesion, whereby when you stretch it, okay, it goes away, okay. So and you also exclude any other forms of your white lesions and red lesions for your diffuse non-homogeneous type of leukoplakia, okay. So these are some examples of where your leukoplakia can be. Okay, so basically it can occur at any site. Okay, so I mentioned earlier there are some particularly high-risk sites for your malignancy changes. Okay, so they include the lateral borders of the tongue, okay, which are either left or right, okay, and palatal lesions, okay. Here's some in your retromolar area and also your flora of mouth, okay. So usually when I see lesions at this side, okay, I usually don't like it, okay. So suspicion for malignancy will be slightly higher in this kind of lesions, right? Okay, so this is a form of homogeneous, okay. So basically the ones shown are basically homogeneous, okay. So you can see that most of the time leukoplakia are more in the plaque-like. Okay, they are not really thin like your OLP. Okay, they are very thick. Okay, and you might at first sight think it's like your candida. Okay, so you will try to rub it off, and most of the time you won't be able to rub it off. Okay, so here also on the along the gingiva, okay, attached gingiva of the tooth. Okay, you can also see. So basically, there are no adjacent cause of the maybe causing trauma, whatnot. Okay, they are just basically white suddenly there. Okay, so leukoplakia, as mentioned before, it can be homogeneous or non-homogeneous. Okay, so for the non-homogeneous, besides having your red and white areas, okay, they can also have two other appearance, okay. So you have nodular leukoplakia, okay. So here you can see some form of outgrowth, okay. So maybe there is some swelling a bit at that area, okay. So it's a rounded outgrowth, okay. However, for your verrucous leukoplakia, okay, so this one is a bit more papillary, okay, papillary in the clinical appearance. Okay, I think because we have another lesion that we call proliferative verrucous leukoplakia. Okay, so it somewhat looks the same. Okay, and these are some of the white lesions that you will need to exclude, okay, before you come to the diagnosis of leukoplakia, right? Okay, so histology of leukoplakia, okay, when we take a biopsy of the lesion, okay, so this is basically what it looks like, okay, so it's a white lesion, right? Okay, so can you see my cursor? Yeah, I hope you can see my cursor. Okay, right. Okay, so here along the most superficial area, okay, is basically the keratin layer. Okay, so in leukoplakia, because it's a very thick plaque lesion, okay, so this one, the keratin layer will be thick lah. Okay, so you have a hyperkeratotic, okay, or if it's because most of the time our surface mucosa is your parakeratinized stratified squamous epithelium. Okay, we can call it hyperparakeratinized also. Okay, so and then the epithelium appears slightly thick, right? Okay, so here because it's a type of cross section, okay, so it might look like you have elongated rete ridges. Okay, but actually these are just thickening of the surface epithelium, okay, and it we call this like slightly arcading pattern lah, okay, but it's not of worry, okay, and then the underlying connective tissue is very normal, okay. So these are for lesions that do not have any precancerous changes yet. Okay, so they are very normal. Okay, epithelium looking, you just have thickening of the keratin layer only. Okay, whilst the next lesion, okay, is still considered leukoplakia. Okay, you have a very thickened area of your keratin layer. Okay, but you can see there's some changes in your epithelium. Okay, so can you see the difference between the first picture and this picture? Okay, so basically here you can see that the basilar cells, the basal cells, okay, are showing different shapes and sizes. Okay, so this is what we call cellular pleomorphism. Okay, so here the cells have different shapes and sizes, and also some cells have a bit larger of the nucleoli compared to others. So that's where you have your increased nuclear cytoplasmic ratio. Okay, so those are some of your cytological atypia that they can have if this lesion has precancerous changes, which we call dysplasia. Okay, so basically this epithelium is dysplastic already. Okay, so and the changes goes up to the two-thirds of the epithelium. Okay, so this can be considered as having moderate dysplasia. Okay, so we have a few degrees of dysplasia. Okay, so this, if it goes up to the two-thirds, you can have moderate dysplastic changes in the epithelium. Okay, so for lesions like this, usually we will note to the clinicians that this patient will need quite frequent review lah. Okay, so that we can monitor the changes that's happening on the lesion, right? So the next lesion will be proliferative verrucous leukoplakia. Okay, so it's a basically it's a form of leukoplakia, okay, with verrucous appearance, and it affects multiple sites, okay, which is different from leukoplakia. Leukoplakia usually affects one site only, okay, but for proliferative verrucous leukoplakia, you usually find it at many sites, okay. So it can involve one arch, okay, it's either involving the maxilla only, or it can only involve the mandible, or it can involve all quadrants, okay. So this lesion has a progressive clinical cause, okay, and it's associated with highest proportion of oral cavity cancer development, okay. So sometimes this lesion can be found, okay. Okay, so these are some of the cases that we can see. Okay, so you can see it's very thick, okay, and it's very diffuse. Okay, it's involving up to the midline. Okay, for this lesion, it crosses the midline. Okay, some of the lesions may appear very small like this, but they are in multiple sites. Okay, so this is what you call slightly verrucous, okay, meaning that it doesn't have a very smooth consistency and texture of the lesion, okay. So you can see there's some rough edges, okay, and then some thickening is slightly thicker than others, okay, so you have somewhat of a bulging appearance, okay. So criteria for diagnosing your PVL, okay, so it affects more than 2 different oral sites, okay, existence of a verrucous area, okay, initial clinical presentation, it can be in the form of flat white lesions, okay. So that's the thing, it's difficult. For early lesions, you may not have the verrucous appearance yet, okay. And may also sometimes have a lichenoid clinical appearance, okay, which is very hard to diagnose this kind of lesions, okay. So histology-wise of your PVL, okay, different from your leukoplakia, right? But you do have some features, okay. You still have thickening of the superficial keratin layer, okay, you still have that hyperkeratinized or hyperparakeratinized areas, okay, and you can see that the relative pegs have a more bulbous and more dropping down appearance, okay. So this is what we call verrucal, okay, or verrucous, okay, typically what it looks like in your H&E slides, okay. But with PL, you also have a spectrum of histological changes, okay. You can have only hyperkeratosis, which is only involving the keratin layer, okay. So again, it can have some form of dysplasia, okay. So here, I think this particular area is starting to have some dysplastic changes, okay, while the others are very normal looking, okay. So verrucous hyperplasia, okay, this type of like almost elephant shaped relative pegs, okay, which is very bulbous, but they have the same height, okay, within the connective tissue, okay. This is what differentiates it from your squamous cell carcinoma, okay. So usually it's the same height, okay. Verrucous carcinoma also can be the spectrum if this lesion progresses lah, okay. So verrucous hyperplasia, okay, more the epithelium is usually of the same level, okay. While for verrucous carcinoma, sometimes you may have more of exophytic growth lah, okay. Is equal, is more of you have more papillary projections outside in your verrucous carcinoma, okay. So you can also find early lesions of your squamous cell carcinoma, or if it's very papillary, it may also become your papillary squamous cell carcinoma. So that's the difference between leukoplakia and PVL, okay. And the thing with PPL is that sometimes because you have multiple sites of the lesion, you might want to consider taking a few sites for H&E examinations, because sometimes each site may have some different changes, okay? So we don't miss the malignant changes, okay? So these are other examples of the spectrum, okay? So here is just basically thickening of the epithelium, okay? And then maybe you have a slight basal cell hyperplasia, meaning there's more basal cells, okay? They are being hyperplastic, okay? So here you start having these plastic changes, okay? So here maybe it's just mild dysplastic changes because it only covers the 1/3 of the epithelium, okay? So moving on, here this is going to 2/3 already of the epithelium, so moderate dysplasia, okay? So here you have the whole epithelium is involved, okay? So here you have severe dysplasia, okay? And here you have somewhat of your verrucous hyperplasia, okay? And here is how your verrucous carcinoma will look like, okay? You can have this cupping or converging effect, okay, in the just beneath the epithelium, okay? So I'm sure this histopathological image you're quite familiar, okay? So these are your keratin pearls already, okay, meaning that the lesion has progressed to your squamous cell carcinoma, right? Okay, so moving on to the next lesion, okay, is your erythroleukoplakia, okay? It's a basically a red lesion, okay? It's a predominantly fiery red patch that cannot be categorized clinically or pathologically as any other definable diseases, okay? So it's quite similar to your leukoplakia, except that it's red, okay, when you have the erythroid in front, okay? And it's also a diagnosis by exclusion, okay, like your leukoplakia, okay? Some of the clinical features that you may find in these lesions, okay, you can have well-defined areas, okay? Some areas can be flat or having a slight depression, okay? So you have redness of the mucosa, okay? Sometimes it have a matte appearance, okay? So inflammatory conditions must be excluded, okay, if it's a reactive lesions, okay? So if you have patients maybe complaining of pain or burning sensation inside the mouth, okay, so you can rule out any other probably reactive lesions and also any underlying systemic inflammatory conditions, okay, before diagnosing your erythroleukoplakia. But the thing is with oral erythroplakia, okay, most of the time the diagnosis is very late already, okay? So either histologically when you take the biopsy, okay, it shows very high grade or severe epithelial dysplasia, or it's already your squamous cell carcinoma, okay? So these are some of the clinical presentations of the lesion, okay? It may look very initial lesions like this, okay? You have slightly whitish, okay, and slight areas that are erythematous, okay? But it's on the palate, okay, which is one of the high risk sites, okay? Besides that, you can also have this presentation is a total red area or erythematous area, okay? And also here is found on the floor of mouth, okay, where you have the erythematous mucosa, okay, with some patch of your whitish lesions, okay. So because again your erythroplakias are usually found in late stages, okay. So when you take the biopsy of the lesions, okay, you may have these changes already, which is quite severe dysplasia, okay, hyperdysplasia, which is involving the whole thickness of your epithelium, right? okay? Or you can also have this presentation ready, which is again your squamous cell carcinoma, okay, which is just starting to happen here. So because this is quite initial, it can be your you can see that it is easily diagnosed as SCC, so it's your well differentiated type. Okay. So another lesion, I'm sure you've heard of this in clinics also, is your oral submucous fibrosis. I think just this morning I diagnosed one case of oral submucous fibrosis. Okay. So clinical features is basically characterized by fibrosis of any mucosal tissue inside the mouth. Okay. So in this kind of lesions, there's a higher risk for development of your cancer. Okay. So in moderate to advanced cases, okay, it can also go further back. Okay. Involving your soft palate, your uvula area, and also your oropharynx towards your esophageal area. So the clinical features basically depends on the stage of the disease. Okay. So sometimes patient may come to you complaining of pain or burning sensation. Okay. Most of the time it's burning sensation, and they also have symptoms of limited mouth opening. Okay. So initial signs that you can see clinically, there's pictures after this, is basically a pale mucosa. Okay. Sometimes you can have areas with petechiae, okay, but most of the time it's just very pale and white looking. Okay. So when this lesion is left to be progressive, okay, you may have development of your fibrous bands. Okay. It can involve the areas, the more frequently involved areas will be your cheek region, okay, your buccal mucosa, okay, but you can also have involvement of your lips, okay, and also your soft palate. Okay. So when you have this, when patient starts having the fibrous band, okay, this is when the symptom of your limited mouth opening will start. Okay. So here are some examples. Okay. So you can see it's very pale. Okay. It's white and pale. Okay. So here basically there's a lot of fibrosis. Okay. And then you have some erythematous areas. Okay. Which may be why the patient is complaining of burning sensation. Okay. So again here you can see whitish pale areas, okay, involving the soft palate area and also your pterygomandibular raphe area. Okay. So these are the sites that are mostly affected with this lesion. Okay. So here is involvement of the lips. Okay. It's very subtle. Okay. You can just see probably a very faint white outline of the fibrosis. Okay. And then usually patient would have repeated mouth opening. You can see the mouth opening from your incisor edges of your incisor tooth. Okay, it's very limited. Okay. This patient I think still doesn't have yet the limited mouth opening. Okay.
Recording stopped.
So
Recording in progress.
histology of submucous fibrosis. Okay. So most of the time you have this very dense collagen just beside your epithelium. Okay. So your epithelium can be thick, slightly thick, okay, or hyperkeratinized, okay, or it can be very thin like this, okay, meaning there's atrophy already lah. Okay. So here you can see that it's very collagenized, okay, or very dense. Okay, you don't really have much vascular component. Okay, you don't really have your blood vessels, which is a very classical feature of this lesion. Okay, you have hypovascular fibrous connective tissue. Okay, so sometimes the epithelium can have dysplastic changes. Okay, sometimes, most of the time they don't. Okay, just sometimes suddenly it becomes your SCC. Okay, so that's why your oral submucous fibrosis, the exact etiopathogenesis has not been established yet, because the mechanism of how it changes without any risk factors, okay, and how it changes without any dysplastic changes initially prior to becoming your SCC is also question mark. Okay. So moving on to the next lesion is oral complainants. Okay, so I think most of you may have heard this. It's very common. Okay, it's the most common type of immune lesions in clinic. Okay, so it's a disease with bilateral white reticular patches affecting your buccal mucosa, your tongue, and also gingiva. Okay, so clinical variations, you can have these 6 appearance. Okay, it can be reticular or lace-like, which is the most common type of presentation. Okay, can also appear plug-like. Okay, so bullous, erosive, and atrophic types are a bit difficult for you to differentiate clinically. Okay? Because sometimes some of vesicle have ruptured. Okay, so they just become an erythematous area. Okay, and you also have papular type. Okay, so most of the time you will have this on your cheek region. Okay, most of the time. Okay, however, you can also apply your lip and also your gingiva and tongue region. Okay, so histopathologically is very classical.
Recording stopped.
Okay, I think we go through the clinical first. Okay, so this is an example of how a papular OLP can look like. Okay, so this is a papular type. Okay, this one is the most common type, which is your reticular. Okay, and this is an example of your plug type lesion. Okay, so this one is actually your bullous. Okay, but as I mentioned, okay, some of your vesicles have already ruptured. Okay, so it looks like it's erosive already. Okay, so this is an example of your erosive lichen planus. Okay, how you differentiate between the two is that usually patients with bullous presentation, they will inform you that it started as a vesicle or you have a fluid filled swelling prior to it becoming ulcerated like this. Okay, so the last one is atrophy. Okay, so here you can see it's very red. Okay, it's like it's scorching red and very bare. Okay, so this is the type of atrophy. Okay, which is not very common. Okay, but some patients may have this. Okay, and your histology is very classical for your OLP. Okay, I know maybe you describe this as elongated or sawtooth edge of your retipex. Okay, so this is how your sawtooth edge of the retipex will look like. Okay, and then you can see below the epithelium there's a very dense collection of your inflammatory cells. Okay, so for OLP, most of the time the subepithelial band is usually involving your lymphocytes. Okay, most of the inflammatory cells are your lymphocytes. Okay, I know this is not very typical of your band-like. Okay, but you can see that's like here is a bit free. Okay, and the top portion is having more diffuse infiltration of your lymphocytes. Okay, and you can see here at the basement membrane region, you have some of your basal degeneration. Okay, or we call it leucofactive degeneration. Okay, of the basement membrane. Okay, so here is another example. Okay, so this one may have slight atrophy. Okay, because you have a very thin epithelium. Okay, and then again you really make out the outline of the epithelium. Okay, it appears somewhat like a big triangle or your sawtooth appearance. Okay, definitely having your hydropic degeneration. Okay, so here you have a more uniform presentation of your subepithelial lymphocytic band. Okay, I don't really see any civet bodies to show you. Okay, Sometimes you can also have a bit of melanin pigmentation, okay, in the lamina propria area, okay, but this slide also doesn't have it, okay. So we call it melanin incontinence, okay, in some of the lesions, right? Okay, so moving on to the next lesion is your actinic colitis. So basically, this lesion can be found in very fair people, okay, who are exposed to the sun, okay, very long exposure periods to the sun, okay. It's produced by the effect of the actinic or solar UV rays, okay, on the facial and skin region, okay. For the lips, affected side will be your lips, okay. So it's more in farmers, perhaps those who work outside, okay, that's why you always need to have your SPF and also protection from the UV rays from the sun, okay. So lesions can be localized or diffuse, okay. It can appear as white flaky plaques or scaly lesions, okay, with a region of redness, okay. Or you can have white surface, okay, because of the thickening of the keratin layer, okay. Whilst the red color results from epithelial atrophy, meaning there's thinning of the epithelium, okay. So clinically, you may have presentations like this, okay. So the first picture, okay, just shows very dry appearance of the lips, okay. So we call it cirrhosis, okay. And then you can have a bit of thickening of the vermilion border of the lips, okay, which can appear like this, call it hyperkeratosis, okay. Sometimes it can have a slightly mottled appearance, okay, which you can see the lines a bit flaky also like this, okay. And then as some of the lesions progress, you can't really see the outline of your vermilion border or outline of the lips. Okay, so you have blurred demarcations here, right? So here you can also have fissures, okay, very dry, okay, fissures of the lips, okay, and also you can have presence of a flag-like lesions like this, okay. So it can come in any form, okay, clinically. So histological features for this is also quite similar. Okay, you can also have the epithelium showing hyperplasia or atrophy. Okay, it's either thick epithelium or a thin epithelium. Okay, so varying degrees of keratinization is either thick or thin also. Okay, so here you can also have cytological atypia, okay, if it's progressed already, okay. And within the connective tissue just below the epithelium, you can have this solar elastosis, okay, which is a basophilic degeneration of the collagen due to your sun UV rays, okay. And sometimes you can have somewhat appearance of your OLE, okay, lichenoid inflammation, okay. So actually the picture in A is your actinic colitis, okay, and then the B is after they had some treatment with photodynamic therapy, okay, so the epithelium becomes a bit more normal, okay. So here is very thin, okay, so you have epithelial atrophy, okay. I know it's not very clear, okay, but you can see is the connective tissue just below the epithelium is slightly a bit more bluish, okay. So this is what we call your solar elastosis. I think the picture after this will be a bit more descriptive. Yeah, okay. So here you can have this basophilic degeneration of your collagen, okay, caused by the UV ray, okay. So otherwise, here you have epithelial atrophy, although you have thickening of the keratin layer, okay. So these are just some of your sebaceous glands, okay. Okay, so moving on to palatal lesions in revert mucus, okay. This lesion is not very common. Okay, maybe it's more common in those who are still using cigars, okay, where they do reverse smoking. Okay, the cigarette or cigar is held inside the mouth and usually is residing on the palatal region. Okay, so where in regions where it's practiced, okay, 50% of oral malignancies are found on the hard palate. Okay. This site is usually spared for OPMDs, okay, mostly, okay, except for pipe smokers. So again, you can have thickened white plaques on the palate. Okay, some of it may show because if they have a bit more thickening, it can appear slightly nodular. Okay, and then you have excrescence around orifice of palatal mucosal glands. Okay. Sometimes they can have yellowish or brown staining, okay, erythema or ulcerations. Okay, it can be mixed appearance. It's either your red or white lesion and also with some tobacco staining. Okay, so here you can see punctate at the orifice of the minor salivary glands. Okay, it appears a bit erythematous. Okay, due to the smoke or heat, okay, changes of your cigar pipes. Okay, so this you have some initial lesions may look like this, okay, most of the time, okay, but you can have lesions that have just a very erythematous looking area. Okay, they don't really show the punctate orifice of the minor salivary glands already. Okay, so I'm sorry, this picture is a bit blurred. Okay, so here is already those who have transformed to malignancy. Okay, so histologically wise, okay, again, most of the time for this type of lesions, they are already very early lesions may not have any dysplastic changes. Okay, so these are some dysplastic changes, moderate. Okay, and this is severe. Okay. This one is not very clear, but there are some squamous change in the sebaceous glands. Okay, squamous changes in the sebaceous glands. Okay, so moving on to oral lupus erythematosus. Okay, this one is among the two that have been added. Okay, in the 2020 classification. Okay. So it's basically a chronic autoimmune disease, okay, and can be divided into three forms. Okay, it's either your SLE, your systemic, it can be drug-induced, and it can be your discoid lupus erythematosus. Okay, so oral lesions may manifest in 20% of patients with SLE. Okay, some of the clinical features, they can exhibit clinical presentations of OLP. Okay, affected sites are mostly your buccal mucosa, palate, and lips. Okay, carcinomas developing from these lesions are rare. Okay, but they can arise on the lips. Okay, it's not always possible for you to distinguish between your OLP and your OLE clinically. Okay, you will still need histological confirmation for the diagnosis. Okay, so sometimes because these lesions histologically mimic your OLP instead of your lupus erythematosus. Okay, so these are some lesions that can arise from your lupus erythematosus. Okay, classical feature also for your systemic, for your SLE or your OLE. Okay, usually the lesions affect the palatal region, okay, which you can somewhat differentiate from OLP because most of the time your OLP doesn't involve the palatal area. Okay, so your SLE type of ulcers, okay, likes to begin at the palatal region. Okay, so for you to also distinguish between OLE and OLP, okay, which is very classical for lupus erythematosus patients to have this kind of butterfly rash, or we call it mala rash, okay, which is affecting your malar region and also the slightly above the lip region. Okay. So this clinical picture, I think is progressive already. The lesion has been there for quite some time, okay, without any intervention, okay. So it's become very like a reactive growth already, okay. You can see it's slightly papillary, okay. So these are the changes that you can find in your OLE, okay, which is a bit different from your lichen planus, okay. So here you can have atrophy or for thickness of the epithelium to be thick in your OLE is a bit rare. You usually have the atrophic epithelium, meaning there's very thin epithelium, okay, because of the ulceration, okay. You can have your basal vacuolar damage, okay. So you see a bit of vacuoles, okay, slightly in the epithelium, meaning that it's separated already, okay. And then you also have the melanophytes, okay, which are basically your cells that produce your melanin, okay. So you also have this intense lymphocytic infiltrate, which is how it differs from your lichen planus is that the inflammation usually goes deeper, okay. For your lichen planus, it's usually just subepithelial, okay. But for your for your lupus erythematosus, it goes deeper within the connective tissue, and also you have it inside your vessels, okay. So you have we call it perivascular inflammation, meaning that you have a lot of inflammatory cells, okay, surrounding your blood vessels or vascular channels, okay, deeper within the connective tissue, okay. So this is a bit how you differ them histologically, okay, because it's hard to differ clinically, okay. So, and then the last lesion that was included in the 2020 classification is your dyskeratosis congenita, okay. I've also not come across this kind of lesion, okay. So it's a rare cancer-prone inherited bone marrow failure syndrome, okay. And the pathogenesis is due to gene mutations, okay. So these are genes that are involved in telomere structure and functions, and also okay, so basically in the DNA lah, okay. So the gene mutation is in your DKC1 gene, okay. So quite classical for this lesion, you have a triad of these three, okay. Presence of your dysplastic nails, okay. The nails may appear like this, okay. And they also have a oral leukoplakia, okay, lesions inside the mouth, and they have a lacy reticular like skin pigmentation, okay. Can you see the whitish areas, okay. So it appears slightly lace-like, okay. So again, this one I took from a paper, okay. So they also reported the three triads, okay, the dysplastic nails, okay. And then although it's not very clear, but they said that they indeed have a very faint form of leukoplakia intraorally, okay. And here you see the lace-like skin pigmentation, okay. So before this it was white, okay. This one is slightly a bit darker, okay. And here you can see histologically there are some along the basement membrane, okay. Vascular lymphocytic infiltrate in the dermis, okay. So it's not shown in this picture, okay. It's quite similar to your OLE previously, okay. So we've gone through the list, okay. But there's two more conditions that they added, okay. So which is your oral lichenoid lesions and also oral graft versus host disease, okay, which is included also as your MD. So oral lichenoid lesions, okay, they are typically the same to to your oral lichen planus, okay, but for your OLL, most of the time is unilateral, okay, is unilateral, while your OLP is most bilateral, okay. Clinically, it will be a bit difficult for you to differentiate it if, let's say, the lesion is just unilateral, okay, but your OLL is most of the time can be induced by drugs, okay, or can be induced by some of the restorations that we do in clinics, okay. So clinical features for your OLL, okay, again unilateral, okay, it can be in close contact with any dental restoration. So most of the time it's your amalgam lah. Okay, previously we do a lot of amalgam restoration, okay. So some patients develop this kind of lesions right beside the amalgam restorations, or any other types of dental material that they may be allergic to, okay, they might have these lichenoid lesions, okay. So they can also due to your food intake, okay. So besides your drugs, okay, some of your herbs can also cause this kind of symptoms, okay, like your cinnamon, okay, and oral lesions of graft versus host disease, okay. So basically it's quite similar to your OLP kan? It has that reticular white lacy presentation, okay. So here you can see that there's an adjacent amalgam filling, okay, which is very close to the lesion, okay. So this one, A and B is caused by drug induced, okay. So so far I think any drug can basically cause this, okay. And in Malaysia, okay, we have especially in the elderly population, hypertension, diabetes, and hypercholesterol is very common, okay, triad for the patients who have, and for them to be taking some of these drugs, okay. Sometimes, okay, not all the time, they can develop this kind of lesions, okay. So histologically wise, okay, it's quite similar to your oral lichen planus, okay. Although you don't have the, if it doesn't appear as a subepithelial band like this, okay, it can also appear diffuse, okay, diffuse infiltration of your chronic inflammatory cells, okay. So for OLP, your epithelial band is usually just involving your lymphocytes, okay, most of the time, but your OLL is a mixture, okay. You have lymphocytes and also your plasma cells, okay. The picture is a bit blurred, so I can't really show you how to differentiate your plasma cells and lymphocytes, okay. So this arrow actually highlights, okay, perivascular inflammation, okay, which is where you have the inflammatory cells surrounding your blood vessels, okay. This one is not very clear, okay, but here you can see, okay, just ever so slightly beside the vascular area, okay, or your blood vessels, okay. You can find this also, okay. So oral versus host disease, okay. So clinical and histopathological presentations are similar to your oral lichen planus in patients developing autoimmune, okay. It's usually after any transplant, okay. If a patient is having any bone marrow transplant or any other, nowadays we have stem cell transplantation, we have bone transplantation or grafts, okay. So some patients may have may not receive it well, okay. So they can develop this oral graft versus host disease, okay. It can appear in acute or chronic forms that usually involve several organs, okay. So clinical features, some of the oral lesions, okay, they can have a lichenoid appearance, okay. So you have erythema, you can have atrophy or ulceration, okay. I think I've come across one case where the lesion was in form of erythematous ulcerations, throughout the oral cavity. Okay. So here are some clinical examples of how the patient may appear like. So the ulcers may involve, buccal mucosa or cheek region. Okay, it can also involve the palatal region. Okay, it looks almost like your aptus ulcer. Okay, aptus ulcer-like lesion. Okay. So here is a bit painful. Okay, it's involving the lateral borders of the tongue and also slightly in the floor of mouth. Okay. So most of the time for OGBHD, okay, the patient will come with very diffuse ulcerations like this. Okay, and sometimes you may need to dig for further history. Okay, and sometimes the patient don't really want to tell you that they had a transplant done. Okay. Sometimes, okay, but if they have the history, they give you the history, okay, so this can be included in your differential diagnosis also. Okay, so those are the ones that are included, okay, but in 2020 they will also remove one lesion, okay, which is your oral epidermolysis bullosa, okay. Because there was not enough evidence, okay, for this type of lesion for it to stay as an entity in the classification. Okay, so your OEB, okay, was included as a OPMD in your 2007 classification. Okay, it has a specific potential and usually is for malignancy, but it's not well documentized, okay, meaning that I think throughout the years not many cases have been found and reported and also documented. Okay, so it has been found in reported cases before that your SCC usually more commonly develops for your recessive dystrophic type of your epidermolysis bullosa due to your sun exposure. Okay, so clinical features, they vary in frequency and severity according to the phase of the disease. Okay, so intraoral manifestations, okay, patient may have multiple caries affecting the entire dentition. They can have severe gingival inflammation. Okay, they can have a small jaw, macrosomia. They can have ankyloglossia. Okay. Which is tongue-tied, okay, and obliteration of your oral vestibule areas. Okay, so this is somewhat how your OEB can look like. Okay, it's very severe. Okay, for this patient. Okay, you can see the tooth. Okay, is very treated. Okay, and also has multiple caries lesions. Okay, so this patient is a child patient, okay, so he needs multiple stainless steel crowns for replacement to maintain the space, okay, because you don't want to lose the space and all the tooth, okay, if not how the patient will function to speak and eat, right? So just briefly, I will touch upon management of OPMD. Okay, basically there's no specific guideline. Okay, but this one is a newly published consensus for guidelines on management of oral potentially malignant disorders. Okay, you can see there's Prof. Salman here. Okay, OPMD is usually his area. And this article includes recommendations for some of the OPMDs and how to manage. Okay, so because most of the lesions have dysplastic changes, okay, so usually it's in the form of behavioral management, okay, and also some dietary modulations. Okay, so here they did outline some of the steps or procedures that you can choose for the patient based on what you find with the biopsy, okay, and also if the patient is having any social habits, okay, such as bitter quick chewing, or if he's a tobacco smoker, okay, so you can have some behavioral changes for these patients, okay. So here they also include your photodynamic therapy, okay. We have a few centers have this, okay, but I'm not really sure about the cost of it, okay. So these are for leukoplakia, and this is some for your oral submucous fibrosis. Okay, it's about this article. The tables are very easy to follow. Okay, although others are a bit very scientific. Okay, so here you need essentials for cessation of the habit or any physiotherapy if the patient is having limited mouth opening. Okay, so you can also have some nutritional supplements for the patient, okay, or intralesional injection of hyaluronidase, okay, and then these are some options, optional options that the patients can go through, okay, but these are for mouth opening which is more than 20 mm, okay, it's less than 20 mm, okay, so it's usually surgical treatment, okay, you will need to excise the fibrous bands, okay, on your buccal areas or your retro or your pterymandibulorape areas, okay, whichever area is involved with the fibrous bands, okay. Okay, so for non-dysplastic OLP, okay, most of the time for lymphoplanas or any types of ulcers in the mouth, we usually use steroid creams most of the time. Okay, it's either having your dexamethasone, or a slightly more potent one will be your clobetasol, okay, in managing these kind of lesions. Okay, sometimes some patients will also need oral prednisone or oral prednisolone, okay, just to help manage the ulcerations. Okay, ulcers heal fast with steroids. Okay, but speaking of that, long-term steroid, either topical or systemic, is not very good for the patient. Okay, because for topical ones, you might have further thinning of the mucosal area. Because in OLP, the patient already has a very thin mucosa epithelium. Okay? If the steroid is applied not according to prescription, okay, and I would say it may be abused, okay, so it will cause further thinning of the mucosal area. Okay, for systemic prednisone or systemic steroids, I'm sure you know you can have you can have some steroid crisis, okay, and for patients who are diabetic and on drugs, okay, you can also interfere with their blood glucose level, okay. Besides that, having prolonged ingestions of your steroids can also lead to high risk of candida lesions inside the oral cavity. Okay, so just roughly treatments of this, because there's no algorithm basically for treatment of your OPNP. So it's basically case by case. Okay, but these are just some of the references that we use, okay, in managing, right? So I think that's the end of my lecture. Okay. So if there's any questions at all.
Thank you very much, Dr. Nurul Mahamad Apandi, for giving us such informative and interesting presentation. Okay, ladies and gentlemen, now come to the Q&A session for 30 minutes. I will take 3 questions from the participant first. Before asking, please introduce yourself. Participant who want to ask question are welcome to raise their hands. Baik, selanjutnya adalah sesi tanya jawab selama 30 menit. Bagi teman-teman yang ingin bertanya, dipersilahkan untuk mengangkat tangan dan memperkenalkan diri sebelum menyampaikan pertanyaannya. Untuk sesi tanya jawab kali ini akan saya buka untuk 3 orang penanya terlebih dahulu. Bagi teman-teman yang ingin bertanya, dipersilakan untuk mengangkat tangan. Dan bagi panitia yang ada di kelas mungkin bisa langsung memberikan mic. Ya, dipersilakan saudara yang ada di depan.
Berdiri.
Ini langsung ngomong aja, Mas.
Ngomong aja.
Okay, firstly, thank you, doctor, for your explanation. Let me introduce myself. My name is Diana Haifa, and I have two questions here. And the first one is, what kind of precancer lesion are commonly found, especially in Southeast Asia? And what factor that make this lesion frequently appears on Southeast Asia? And the second one is there any specific hints on each precancer lesion that appears on histology, so we, as a clinician, can easily diagnose the disease? Maybe that's all. Thank you, doctor.
Okay, thank you for the questions. Okay, so for the first one, what type of lesions are most commonly found in Southeast Asia? Okay, I think because of our social habits here, okay, especially in Sri Lankan or Indian areas, patients, the society is still using your areca nut chewing, okay. Tobacco, okay, is easily found in the market, although the authorities have put somewhat of ban onto it, okay. Your lesions, such as your precancerous lesions that are very prominent, will be your lichen planus. For that, oral submucous fibrosis is very common because of the bitter quick chewing, as this provides. There are some changes from the areca nut and the slate lime that they use that produces more fibrosis in those areas. Okay, so they have more of your oral submucous fibrosis. Okay, so I think in our area, more of your OPMD, the most common one will be OLP lah, oral lichen planus. Okay, those are the two lesions. Leukoplakia can also be found, okay, but I think the other two, OSF and OLP, are more common. Okay, your next question was the histology, right? How to classical histology. So clinically, I know the lesions, they are overlapping, okay, because most of the presentation is ulcer-like, okay, either if it's plug-like, white lesion is either plug-like, okay. So for histologically, some lesions have classical presentations, okay, such as for your OLP, you have the sawtooth appearance and the subepithelial bands, okay. For your OLE, your oral lupus erythematosus, okay, you have somewhat appearance of your OLP, but the inflammation goes deeper within the connective tissue, okay, and you also have that perivascular inflammation surrounding your vascular channels, okay. It can be found in other forms of OPMD, but it's more prominent in your OLE most of the time, okay. For your OSF and others, okay, OSF histologically is a bit difficult to diagnose, basically, because it depends on the stage of the disease. And as I mentioned before, because the mechanism, how it progressed to become malignant, okay, has not been properly established, okay. So it's a bit hard for it to have a very classical histological feature, okay. And other lesions, most of the time they have the dysplastic changes lah, okay. It's either your mild, moderate, or severe dysplasia. So usually, if it's dysplastic already, usually we have a comment with the clinicians to continue monitor or reviewing the patient, so that the patient is not lost after the review period, so they can come for follow-up, okay, so that we can monitor the changes in the lesion itself. I hope that answers your question. Any more
Okay, thank you
questions?
Dr. Ines for the explanation. Saya tanyakan kepada saudari Diana, apakah sudah cukup?
Iya,
Oke, karena sudah cukup.
Thank you, dokter.
Okay, thank you.
Oke, selanjutnya bagi penanya yang ingin bertanya mengenai OPMD atau yang lainnya, dipersilakan untuk mengangkat tangan. Baik, dari kakak yang ada di sebelah sepertinya. Langsung berdiri aja. Oke, sudah terdengar.
Thank you for opportunity. Let me introduce myself. My name is as a data student from class of 2022. I have listened to your explanation, Doc, about the histology of proliferative verrucous leukoplasia atau or PVL, but I am still confused about some of the histopathological spectrum of PVL. So I would like to ask that do the PVL histology always accompanied by the appearance of verrucous carcinoma, capillary squamous cell carcinoma, and oral squamous carcinoma all at once, or can it only one of these histology appear? Maybe it's all. Thank you, Doc.
Okay. So answering your questions for yes, PVL is a very hard lesions to diagnose. Okay, so if you're confused of the spectrum, yes, it's confusing. The thing is with PVL, okay, because it's a spectrum, all of the changes that you mentioned, papillary, or papillary is still your squamous cell carcinoma or verrucous carcinoma and verrucous hyperplasia. All of these features can be found in one lesion. Okay, so maybe because it's happening at multiple sites, okay, sometimes different sites they may have progressed through different stages. So sometimes they don't really follow the spectrum, but that's why for PVL we need to take multiple sites during biopsy, okay, so that we don't miss any of the malignant changes. Okay, if we find verrucous hyperplasia features or verrucous carcinoma features, okay, so in one of the sites, okay, so we usually the management will go from the verrucous carcinoma or verrucous hyperplasia diagnosis. Okay, so even though it has a spectrum, it has simple hyperkeratosis in one area, but one area has the verrucous carcinoma or papillary SCC. So the management will follow the papillary SCC site for management of the lesion. Okay, I hope that answers your question.
Okay, thank you dokter for your explanation dan terima kasih kepada penanya. Selanjutnya saya buka kembali. Bagi partisipan yang ingin bertanya, dipersilakan untuk mengangkat tangan atau bisa juga langsung berdiri. Oke, sekali lagi bagi partisipan yang ingin bertanya, bisa mengangkat tangan. Oke, dipersilakan dari kakak yang ada di depan.
Thank you for the opportunity, Doctor and Divanda. The doctor, you mentioned before that OPND generally is less distinctive in appearance. And as a clinician, is there any certain characteristic we should look out for in the early detection of precancerous lesions? Or is there really no way of knowing until the lesion starts to visibly manifest? And if not, in the context of early detection, which OPMD can be early detected or is the easiest to detect and diagnose at the initial assessment for early detection of precancerous lesion? I think that's all. Thank you.
Okay, good question. So for the clinical side, okay, so not only pertaining to OPMD, okay. So what I like to tell the students is that any lesion, okay, the patient, you need to take a very good history, okay. Also the social history is very important, okay. Seeing that for social history, you can detect if the patient has any risk habits that may contribute to the lesion. Okay, say patient is smoking, okay, or nowadays they're using vape, right? Okay, if they have, especially for Indian patients, okay, or maybe indigenous people, they may be taking your bitter quid chewing, okay, or tobacco consumption. Okay, so some is you can find the social habits for the patient. Okay, so and then you see inside, you do your clinical examination, then you find lesion inside the bum. Okay, so first for clinicians, you ask the history. Okay, say for when did the lesion come? Okay, when was the first initiation of the lesion? How long was the duration? Okay, so for ulcers, okay, maybe non-healing ulcers for more than 2 weeks should raise suspicion already. Okay, if the patient does not have any other underlying conditions, okay, or any malnutrition, okay, so non-healing ulcers beyond 2 weeks should mandate a compulsory biopsy for the lesion. Okay, for any other lesions, okay, so you have a swelling, okay, or erythematous area, okay, you can ask the patient also for the history, okay, when the lesion occurred. Besides that, is there any trauma to the area, past trauma? Okay, if there's not, and see the duration of the lesion itself. Okay, so probably the patient may tell you that it has been there for a long time, or if it's been there for 1 month, say perhaps, but it's increasing very rapidly in size. Okay, so that should from you saying that, okay, this must be something wrong. Okay, probably is the swelling is increasing in size for 2 weeks or 1 month. Okay, and patient also is are they having any systemic symptoms? So for malignancies, okay, or the start of any malignancy, sometimes you have you can have systemic symptoms, okay, such as your lymph node enlargement. Okay, most of the time is your lymphadenopathy. Alright, okay. Sometimes if the lesion can also cause hoarseness of the voice if it's already sometimes if it's already metastasized or whatsoever, because I've come across a case whereby the patient had a very large non-healing ulcer on the tongue actually, but already came with hoarseness of the voice, okay, and a very large lymph node swelling at the neck region. Okay, so for on the clinician side, I think a very thorough history, okay, so you include your social history, clinical examination, very thorough also. You also need to not only examine just the oral cavity area, also examine the whole head and neck region, okay, also involving your neck region, okay, because sometimes you might miss anything, okay, especially if the swelling is in the neck already. Okay, I hope that answers the question.
Yes, doctor, thank you very much.
Okay. Any more questions?
Still have a lot of time. Jadi bagi partisipan yang ingin bertanya, masih dibuka lagi untuk partisipan yang bertanya.
Can I ask a question? For Dr. Amy, in your clinical setting, what kind of patients do you usually come across for oral medicine patients? I just want to see if it's a bit more different than what we see here.
Okay. Thank you for the questions, Doc. Actually, I'm not clinical. I'm just lecturer.
Okay.
The clinical is Prof. Maharani.
Prof. Maharani.
But she has
Prof. Maharani.
another schedule, so she can.
I see. Okay. All right. Okay. Do the students know what kind of cases you see actually?
Mungkin Koas bisa jawab apa yang sering kasus yang sering terdapat di klinik. Apa? Kasih ya. Ada mic dulu. Silakan mic.
Currently, we have multiple nurse and the desk of those reference, and we also sometimes follow infections or something.
Okay, so it's quite similar to here also lah. Okay, most of the time. Do you have hospital attachments also during your clinical years for oral medicine?
Yes, we have.
Oh yes, we have. Okay, alright. So maybe in the hospital you see more patients who have probably more systemic involvement, such as your autoimmune. Okay, so your OLE patients usually see them in hospital-based setting. Okay, clinical setting is a bit rare. Yeah. Any more questions?
I would like to introduce myself again. My name is Nurul. I would like to ask and deliver some questions. As Dr. said in your presentation, scrapping are needed in some population to help the clinician to assess the lesion. The question is, there any certain standard procedure that for the scrapping for the precancerous lesion, and how we should dispose this presentation?
Okay, so there's no actually any standard protocol for smears of these kind of blood lesions. Okay, so I think for any white lesions, your first differentials will be your candida for fungal infection. Okay, because it starts as scrapable white lesion, and so most of the time clinicians will always try to scrape off the lesion. Okay, so for OPMD, there's no specific procedure or protocol for you to follow to do the scraping, okay? But for your, if you were to suspect of oral malignancy, okay, I think some investigations before we can do a cytobrush biopsy for your suspicious areas, okay? So it's just the form of the brush that we use. It's very specific. I think maybe you can search for it, a cytobrush, okay? Cytobrush biopsy, okay? Then you will find the information, okay? So that one we will use the cytobrush and just scrape the area. If it's not scrapable and it's a suspicious area, okay, and then we send it for the assessment, for the examination. Okay, but otherwise there's no specific protocol for you to scrape the lesion whatsoever. Okay, but if you were to take the cytobrush swab biopsy, okay, always go for the most suspicious area. Okay, so let's say there's a one big lesion, okay, and then there's white and red lesion. So take in between, take the red lesion, because most of the time the red lesion is more prone to malignancy compared to the white. Okay, so always take the most suspicious area and also the adjacent normal tissue also, so that you have a comparison, okay, between normal and what's the pathology of the patient. Yeah.
Okay, thank you dokter for your explanation. Dari penanya apakah sudah cukup?
I want to ask something.
Okay.
Okay. Based on your experiments, how can be easy to detect for oral precancer lesion?
During our clinical sessions, I think for easy for us to detect, I think because the more we see and the more the soft skill that we have by experience, by seeing more cases, you'll be able to extract more information that probably the patient doesn't want to give away. Or sometimes we can actually in the oral cavity you can find a lot of information without asking the patient prior. Okay, so some lesions are very, how do I say, having slightly classical appearance if you see more cases. So it comes by experience. Not saying that everything, because everything in pathology, like I've learned, is not always textbook. Okay, you can see in the textbook it's supposed to come like this. Okay, but in clinical setting it will be a bit different. Okay, but I think in the form of you seeing more cases day to day, so you have that grasp of knowledge, and also some of the classical features that you may see in some of the patients that you've seen before that may have the precancerous lesions in the oral cavity. Yeah.
Thank you, Doc.
Okay.
Okay, thank you dokter for your explanation. Saya tanyakan kembali kepada seluruh partisipan. Apakah ada lagi yang ingin menyampaikan pertanyaan? Oke, mungkin saya hitung mundur. 3, 2, 1. Closing. Next is a group photo session. The committee can help take a pictures. Okay, everyone is ready. First one, formal pose. I will start counting. Okay, 1, 2, 3. Okay. Next pose is ULM pose. ULM pose. Okay, I will start counting. 3, 2, 1. Okay, well, ladies and gentlemen, we finally come to the end of this lecture. I'd like to thank the speaker for the informative, interesting presentation, and all of the participants for the very active participation today. Finally, give the applause for the speaker and for you all. Thank you for your attention and see you in the next agenda. Good morning. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you.
Thank you very much, Doctor.
Thank you. Hope to see you again. Okay, bye-bye.
Bye-bye.